Okay. Last but definitely not least, I'm a little bit sad. This is my last opportunity to be with you guys, but it's been great. What I'm going to show you, it's just to record. Yeah. I'll just talk loud. So our time together here is going to be spent looking at the Virtual Ventilator. It's a piece of software. This is my little commercial. It's all free, so we're not making any money, but you guys can feel free to go to openpediatrics.org. It's a website where a lot of resources, including a lecture on waveform interpretation, capnography, some of the stuff that I shared with you. You can watch videos, and we also have some written content, as well as this piece of software. It's basically a computer game for mechanical ventilation. And we started in pediatrics, so I'm going to have to confess to you guys that we're not going to see any good pictures of neonates in the animations, but a lot of the principles, really this is all about waveform interpretation, are going to be able to pivot regardless of patient size. So it could be neonatal, pediatric, or even like an 80-year-old person in an adult ICU. I think a lot of the principles are similar across all patient populations.
What is the site?
The site? openpediatrics.org. Yeah. I can pull it up after we're done so you know the address. Okay, so what we're going to do is we're going to step through a couple of cases right now. And this is really how the virtual ventilator works, but you're presented with a little bit of a patient history. So this is obviously not a baby, but a 6-year-old girl with some pigtails, and she's admitted to the pediatric ICU, and this is what we know about her. She's in the PICU for pneumonia. She was intubated, obviously pretty sick to require intubation, and we're called over to the bedside by the nurse, who noted that the patient's oxygen saturations had decreased. So if we want to look at anything, just let me know. So if we want to get a blood gas, we can do that. If we want to get a chest x-ray, we can do that. But we're going to step through kind of the interpretation and mostly focus on the waveforms. So what's grabbing your guys' attention? I'm trying to make this a little interactive. So I'm going to pose to you guys what is interesting or out of place with the waveforms or any of the physiologic values to you guys. I should point out too that this is the tidal volume per kilo, and then all the settings are down here. So right now she's on 28 of pressure over 8 and a respiratory rate of 22 and on 60% oxygen. All right. So good point. I should probably tell you what you're looking at first. So the top waveform, pressure, then flow, then volume. That's usually at least how the ventilators are that I've used interact, but sometimes it can be different, or you can change it. We can also look at the physiologic parameters. So we get an ECG, SpO2 pleth, so heart rate, saturation, blood pressure, and total respiratory rate, as well as the Untitled CO2, where we get the actual value here of 80, and we can look at this, the capnogram itself. Okay. All right, so what looks weird? Definitely a little bit deoxygenated, but yep, go ahead.
Between the waves.
Here?
The expiratory time.
Yeah.
This is not normal.
Yeah, good. Exactly, not normal for sure. So yeah, so excellent. So trap something. Yeah, so I think you guys are on the right track. So basically, I think that's if I saw this, and this would almost be something you could see from like the door, right, or like pretty far away from the patient, it would catch your eye. So basically, we're seeing like some artifact, a lot of like noise basically, during the exhalation portion of the breath. So as the patient exhales, we see that it's not really a nice smooth curve like we would typically see. The gas flow is being interrupted and kind of, yeah, just chopped up a little bit by something. We don't know what it is. Could maybe secretions, constriction, other obstruction, could be a little bit of effort, maybe, yeah. So I think these are all good plans, and I think the principal thing too is what's interesting is you can kind of see that the flow, the positive, the inspiratory flow rather, it's a little bit noisy as well, but it's not as pronounced as during exhalation. And one of the reasons for that is that the peak flow during that period of time is so high that there's probably is a little bit oscillating, but because it's such a high flow rate, you can't really see it as well. And what happens is we only really see this once the expiratory flow gets down to some smaller level. The other things, we can see it a little bit on the pressure waveform. but not too much. And I think you guys are right in the right track. The way that I think about stuff like this is I always try to prioritize in my mind what is, I mean, A, the most life-threatening, and then I can kind of step through what's the likelihood of the things. We talked about some obstruction, could be secretions, could be constriction, could be perhaps effort, and I kind of think to myself, what's the easiest thing for me to rule out and just cross off the list as immediately as possible. So it could be obstruction, that could be a number of things, right? It could be airways constriction, could be mechanical obstruction, could be a pinched tube, could be secretions in the endotracheal tube or in the lungs. It could also be water in the expiratory limb or the inspiratory limb if we're heating, humidifying that gas. So that's probably the one I would say, like, it's probably most likely to be either secretions or water, just by looking at this. That would be my guess. I could look at the circuit, and that's the easiest one to check off that list. So that's why I always talk about, like, just doing the easiest and quickest thing. Just get rid of that immediately. Look at the circuit. Is there any water in there? Nope. Go to the next thing on the list. And I think the next thing on the list would probably be secretions, because that's the next easiest thing to do. So we auscultate, and if it feels really junky, or even we may see, because this is a really severe, if it's secretions, there's a ton of secretions in there, right? Because we oftentimes don't see any real artifact on the waveform at all when kids need to be suctioned. But that'd be another way to do it. I think in general too, the way I think about waveforms, also capnography, is that it's always telling you something, but it's not telling you everything. And so you always have to look at different pieces of the clinical interpretation of that case to convince yourself what the problem is. And so we're going to auscultate, and it's going to sound really junky. It'll probably sound like we need to suction that patient. And that, I think that's my screensaver. Okay, so let's do that. So we're going to increase the oxygen to 100%. Yeah. Yep, volume.
Does the expiratory part of the secretion, does this reflect on the bottom part?
It probably would a little bit, but a lot of times what you'll see, yeah, so I think that you're bringing up probably a good point, and perhaps you would see a little bit of noise in the volume. But usually the volume is just going one way, it's not going in or out, right? So you probably see a little bit of a noise, but probably less than the flow. I think the flow is the most sensitive to look at this kind of thing. Let's look at the Capnogram before we go on. So I know this is all brand new for you guys, and my understanding is that you don't measure end-tidal CO2 as a standard of care. But what does that look like to you? Good or bad, or what do you think is abnormal? So it's definitely not right. Exactly, good answer. So, so really what we would want to see, if we were to draw a normal capnogram over here and compare it, we'd see this beginning of exhalation, it would get right up to the plateau, and we'd have a nice flat line during the alveolar plateau, the alveolar excretion of that alveolar gas during exhalation. So we got some sort of obstruction. That's basically pointing to an obstruction. And one thing that you can do too is, it's not a really sensitive metric, but inside a patient you could technically look at the severity of obstruction by looking at the slope of that curve. And so obviously the steeper it gets, like the more close to 90 degrees, pretty much something like that, it's pretty healthy. No real obstruction, right? At least on the expiratory limb. And then as this angle increases over here, then that gets really severe. This would be really bad, terrible, only gets worse from there. So this is some sort of obstruction. You guys remember what that's called? Or at least the English term? I mean, you can kind of, you have to, I don't know why, but we always...
Phase 3.
Fish tree?
Phase.
Oh, phase 3. Yeah, so it's definitely phase 3 problem. But there's the name, we call it shark fin. It's just, I don't know why we always have to come up with these cute names, right, to remember things. And so we have things like shark fin and some other things that I'll show you as we go on through the cases. All right, so we got some obstruction. We think it's secretions, and that's probably the easiest thing to do, so we'll do that. So I'm going to crank this O2 up to 100%. And this is all like expedited, but we'll suction. And you guys do suctioning like this. Yep. So I don't think I think the literature is probably a little bit more on the side of trying to use inline suction catheters, but they're a little bit expensive. You have to throw away one every single time you use it between patients. Well, I mean, you put it in and then you leave it for their duration of ventilation and then get rid of it once you're done. The thing that we found is, yep.
So if you have an inline suction catheter
Yep.
for the same patient, how frequent you change it?
We only change it if we need to. So as long as the catheter always works, then we never change it, and they get it placed when they're intubated, and we take it out when they're extubated. So that's it. You leave it in there. It stays in there. Yeah, so it's basically this little, the inline suction catheter, so you don't have to remove it. You always keep it in there. You never throw it away. You always use it every time you need to suction. And so what we do is there's a port, basically. It looks like a little Y, and then the suction catheter comes out of there and makes room for the ventilation adapter so that the gas flow can go in and out. And so when you're using it, it's introduced into the circuit, gets fed down the endotracheal tube, and you use it. When you're suctioning, yeah, but so does any catheter. But you pull it out, and it's just like a regular ventilator. So it doesn't affect the ventilation at all. You don't remove it from the circuit. And it's basically like this kind of plastic bag. And the idea is it's just isolated from the environment, so that the patient is never going to have the risk of infection when you go from, gloving up, washing your hands, doing stuff like that. Yep. Yeah. If it's an infection from that subject and you have some organism in a secretion, that organism is going to remain inside that circuit, and so you're not going to be clearing that out. I will say that usually once you have killed it, we will sometimes change the catheters, but not as a function of infection. Usually it's just you've been using it so much that it just got like so gross and clogged up that you just functionally had to change it. I think that for a long time we actually did suctioning just like this, just like you guys. That's why we made that animation look like that, is because that was our practice when we were first starting to build this whole thing. But what we found was, there was increasing literature. We didn't really have that high of infection rates, to be honest, and I think that's really a function of the diligence of our clinicians. So that's the key piece when you're doing open suction, is what we call it, is you just need to use sterile technique. And so if you can maintain sterility during that whole procedure, well, then you're not going to administer any extra risk. But the problem is it's clinician dependent, and all it takes is for you to like scratch your face accidentally and then introduce into the patient, and you've introduced a nosocomial infection. So you can be careful, and I don't think it's necessarily bad. You just need to pay a little bit more close attention. All right, so we did suction, but we took so long that the secretions built up again. Yeah, so SpO2 went up, waveforms got better, and everybody's happy. And CO2 is coming down. Perfect. Okay, next one. So we're going to, again, sorry it's a kid, but we're working on the neonatal cases right now. In the next probably handful of months, we'll be completing the neonatal content for you guys. I know those are the kids you care most about, obviously. Yeah, it's all free. Yep. All right, so this is a kid in the PICU. We can see the most recent ABG here, 12 years old, admitted for status asthmaticus, and we're called to the bedside because the patient seemed to be working a little bit harder to breathe, which is a subjective assessment, but you can sometimes tell. Okay, so how about this one?
Too long for exploration.
Yep. What do you mean by too long?
Working harder. Expired air.
Yep. How can you tell that? Yeah, it's a little bit short. It's fly.
The expiratory, the expiration part of the curve.
Yeah.
Is above. He's not letting all the air out.
Somebody said auto peep. That's a good one. Yeah. All right, so the thing, you guys are exactly on track. So the couple of things that you can pick out, this is always true, right? But it's most important in somebody with reactive airways disease or some obstructive process, even bronchiolitis, is we talk about time constants. And what's the time constant?
Compliance multiplied by resistance.
Man, you guys are good. I said the last group, and everybody kind of nailed it too. As soon as I asked, if I asked a bunch of people in the United States, I think that most people would have to think about it very hard before they gave me the equation. But yeah, so it's.
Next time you do sputum bowl.
Sputum bowl?
Yeah.
There you go. Yeah, you can be a champion in the sputum bowl at the AARC. Yeah. It's like trivia for respiratory therapists and doctors. Yeah, I know it's not a very endearing term, but and the trophy actually looks like a sputum bowl. Like the Cowboys would come in and they just need to spit in something. So yeah, there you go. Yeah. All right, so time constants. So usually I ask people, and a lot of people don't necessarily think about it, aren't as quick to apply the equation and understand the physiologic ramifications. But my answer, if nobody knew what it was off the top of their head, like you guys are, and I'm impressed, I would say everybody thinks about time constants, but you never just do the math. And the way we think about it is interpreting the flow graphic, right? So everybody notice this. We have, like, I would call this flow chop on the inspiratory portion. So we have the increase in flow, and then right before exhalation, it doesn't reach baseline, right? It doesn't go back to zero. So that means if we increase the inspiratory time, we would get more volume for the same pressure. And that's a function of the time constant, resistance times compliance. So in this case, probably high resistance, and that's the problem. But this is obviously a kid with asthma. We probably don't want to increase the inspiratory time. We probably want to do the opposite. If anything, probably reduce it a little bit to increase expiration, because positive pressure ventilation, man, we can do so much work to force that breath in, but we just have to sit back on our hands and wait for it to come out. So during exhalation, we have the same problem. We see it comes back and doesn't reach baseline before the next breath is initiated. So if we were to do an auto PEEP, we would probably find that the total auto PEEP is higher than the actual PEEP, and that would be a function of the airways obstruction. All right, so I mean that's pretty much the problem. The other thing that you can see sometimes, but it's not really that important because the easiest is on the flow waveform, is it just takes a while for the volume to get back to baseline. But we don't really care about that as so much. And if we looked at the Untitled CO2 as well, look how it looks pretty similar to the last case, right? I mean, because it's an obstruction, it looks pretty similar. But it's a different reason. And this one's nice and smooth. There was no suspicion of secretions or anything like that. Let's say the breath sounds are just wheezy, doesn't sound that junky, so the resolution would be if they're due or if they had an order for a PRN albuterol, we could consider that. To medically relax those constricted airways if we think that's a problem. The alternative strategy would be what? If we thought that this kid was already loaded up on albuterol and bronchodilators and we didn't want to give any more medications, what could we do on the ventilator to enhance ventilation? So we want to ventilate more.
Give him more space for expiration.
More space.
For expiration.
Yep.
More time for expiration.
Sure, how are you going to do that? What do you want to do?
Shortening the expiratory time.
Shortening the inspiratory time?
Shortening the expiration so you have more time for expiration.
Yep.
And maybe not making the frequency too high so you also have space for expiration.
Yeah, so exactly. So the goal is to increase exhalation, the time for exhalation. You have a couple of different options. You can decrease the inspiratory time. It might be a little tricky because our volumes aren't that huge or that big, but it's definitely an option. And the other one we talked about was decreasing the respiratory rate. Actually, he didn't say decreasing necessarily. He said just don't increase, but we could decrease for sure. And this is, I think, it always gave me great gratification to come to a bedside in this kind of context. And nobody was really thinking that in order to increase ventilation, you need to decrease your respiratory rate because it's a counterintuitive move. And if I had VCO2 monitoring, so I told you guys about the CO2 elimination, if I was looking at the ventilator, it had like a little number up here, and perhaps it was like 150. Let's say 150 mLs per minute, that's the CO2 elimination of this subject. What I would do is note that number, decrease the respiratory rate, and then watch carefully what happens to that 150. If it starts to go up, well, I've just improved my alveolar ventilation and given more time for exhalation, and the gas at the end of the breath contains more CO2 than the beginning of the breath, so I've done a net benefit for my patient if it went up to like 160, 170. If it did the opposite and came down to like 140, 130 or something like that, then I would just go back to what I was doing and figure out some other strategy. Okay, that makes sense, right? We might as well give bronchodilator, although I don't think we have a cool animation. Nope. Any questions about that? Or anything really at all? For capnography or waveforms?
I've seen you using Senta for transcutaneous.
Yeah.
You use both transcutaneous and untitled for the transcutaneous.
Yep.
Because Professor Smallwood is resistantly using transcutaneous. And since I was there, I'm fascinated with this.
Yeah. Yeah, so transcutaneous CO2 monitoring.
Even I saw Rob using the microstream for many meter space for untitled.
Mm-hmm.
So Professor Shaman, 20 years ago, when he was in France or something like that, he witnessed burn from transcutaneous. So said that no transcutaneous.
Yeah, that's all it takes, right? Is one bad experience.
Could you convince him with the opposite?
Yeah, I think that, so the way that we approach CO2 monitoring is conventional ventilation. Our standard of care is always end-tidal CO2. And if we can do end-tidal CO2, that's what we do. I think that it has less problems. It tells you something about the physiology and it has some benefits over transcutaneous. But we do use transcutaneous in select patients. Those being if we have a patient who's a neonate who is too small to be able to tolerate having an airway adapter there that has too much dead space, then we can put a transcutaneous monitor on that child. And also high frequency ventilation, because you can't do end-tidal CO2 monitoring. And those would be the two principal applications, I think. And non-invasive ventilation. So those are probably the three. So we don't measure end-tidal CO2 during non-invasive, just too leaky. Doesn't really make sense to do it. So we'll use it in those contexts. So premature or just dead space dependent. So if we can't monitor it, but we want some CO2. Sorry?
How to avoid
a burn? How to avoid a burn? Yeah. Yep. Yeah. So a couple of things. I think that the temperatures that the devices that we use now or have available or have purchased operate at much lower temperatures than in the past. So that reduces your risk. The other thing that we do is we'll change the site. So typically we'll have mainly two sites, and I believe it's every 12 hours that we'll do that, and we recalibrate and take everything off every 24 hours to make sure that we recalibrate it in the dock of the device. Don't quote me on that. I guess I'm on camera now saying that, but I think that's our practice. But yeah, so that way you can. Centec, yeah.
There's another variety called radiometer.
Yeah, radiometer. That one I'm not exactly sure. Yeah, that's a lot. Yeah. I think that's that's probably one of the reasons why we went with Centec, because I think it is every 12 hours. So that way, basically, every RT would only have to move it once during their shift. So we do 12-hour shifts. Well, almost all the clinicians, the doctors, everybody's kind of on a 12-hour rotation. But yeah, so those would be the main. we did discuss Centec in the previous group. No, not yet. Yeah, but yeah. So end-tidal if we can, and then Centec if we need to, and that's really I think the general answer. And the answer is we need to sometimes, because we believe that we can really not have to do a whole lot of blood gases when we can use CO2. Oh, there you go. So he's happy to hear these. Yeah. Yeah, and then the different devices also, it'll be device dependent on how often you have to recalibrate. So the longer that you can go in between recalibrations, obviously the better, but you don't want to go so long as that you have introduced error in your device and you're not even measuring the correct CO2. It's also perfusion dependent, right? So you have to pay attention to the perfusion of the subject. So the sites that we'll choose are on the thorax, close central to the body, where when you start to get sick, you may constrict some peripheral vessels, but placing the probe near the chest or on the chest is the best place to do it. Okay. So I think we have probably just one more case, and then that will be a wrap. But let's look at, hopefully you didn't see what I just clicked on. All right, last case. So 6-year-old, but it could happen to anybody. Could happen to a 900 grammer, could happen to your great-grandparents. But we have a 6-year-old admitted to the PICU, severe pneumonia, so relatively ill from a pulmonary perspective. She's been intubated for a number of days, and recently we're called over because the peak pressures increased, and oxygen saturations decreased, and the blood pressure has gone down. All right, so we're in volume control. SIMV plus pressure support, and I'm going to show you a couple different things about that. So number one, you know the square waveform. Oh, what was that? Pressure support. Yeah. So the square waveform is usually indicative of a flow-controlled mode. So this is volume control. You can have like a decelerating waveform. You guys have seen that, where during volume control you can choose what the waveform looks like, and sometimes it can look almost like a trapezoid. It's a little bit more close to what pressure control flow looks like. I mean, it's SIMV obviously, so periodically this patient's breathing. That's what the yellow means on this ventilator. And then we have these pressure waveforms where the patient is having a spontaneous breath, is actuated, and the ventilator is triggered spontaneous pressure-supported breath. Okay, so then the flow obviously too is different during volume control versus flow pressure support or pressure control. You can see it's a more gradual increase. because it's just targeting the flow. It's doing whatever pressure it needs to do to maintain a set flow. And then unlike pressure support, where the waveform is a little bit more controlled and kind of blocky, because it's pressure, it's just targeting the pressure. So that's what that is. So let's look at the monitor values, and then we'll check out the capnograph. So not so bad. And how about that? All right, good or bad, or we don't know. Yeah, definitely not right. Something's not right. So I didn't show you this one. So if you remember all the things that I showed you during the lecture, the answer is not one of those. But it looks really similar to cardiopulmonary interactions because we have kind of a decay right at the end of the capnogram. How about the beginning of the breath? The beginning look okay or bad? Yeah, pretty good. So we have a really sharp rise. We're getting up to what we think should be the alveolar plateau, but then there's no plateau. Where'd the plateau go? This is actually called the iceberg. I told you about all the cute names. The iceberg capnogram is right here. I don't even know if that's really what it's called. Just one of my mentors at the hospital called it that, and everybody I know there talks about that. So if you hear it called something else, feel free. You can make up your own name, but the iceberg. And the iceberg is indicative of, let's get a chest film to see what is going on. Our radiologists are real quick. They come back in like 5 seconds. All right, so that's not good. It's like a whopping pneumothorax, right? So when we were looking at the end-tidal CO2 tracing, what we were seeing was that some of that breath wasn't going back through the sensor, and it was going somewhere else, and it was accumulating in the pleural space. This probably wouldn't be the case forever if you had a pneumothorax that just was brand new, accumulated, and then stopped. You probably would see a more characteristic capnogram, but if you had a chest tube that was continuously leaking, it would probably look something like this. All right, so iceberg equals pneumothorax, or at least potentially pneumothorax.
It's not washing out the CO2, it's just going somewhere.
It's going somewhere else, yeah, exactly. What's really weird is you could almost imagine it being not like tidal ventilation, but you could almost keep ventilating somebody if they had a hole in the side of their lungs. You know, you just keep passing gas through there, and then you just wash out the CO2. That's basically what an ECMO circuit does. If you've ever seen that, it's just like an artificial lung, and you just pass the gas over it one direction. It doesn't go in and come out, it just goes one direction through.
So this won't change after we insert the chest tube?
Let's do it. So we're not going to insert a chest tube, but we'll needle decompress just in the interim to get all that gas out. And if it reaccumulates, we can put in a chest tube. But all right, lots of gas coming out. Everybody breathes a sigh of relief. And waveforms don't look that different. What about the volume? The volumes get better, worse, stay the same? We weren't necessarily paying a whole lot of attention, but they didn't get that much. They didn't get that much better. Why? So we're in volume control. So the volume control, it's always going to servo to that volume and just give more pressure. And so what we were doing was probably the opposite of what you would want to do with a pneumothorax, which would be like reduce the volumes so that the risk of accumulating that would go down. So what the machine was doing was like, I don't know what's happening. It just says, you set the tidal volume of 90 mLs, and I'm going to give you 90 mLs no matter what. And so what happened was the peak pressures were a lot higher, but the volume was the same. So that's why our the volume didn't change a whole lot. Okay, and then we can look at the capnogram. That looks better. Looks a lot more like we would expect. And probably in this case, if we were really treating this patient, or if you had a baby, what would you want to do in this case? Chest tube? Yeah, perhaps. Or alternatively, we could maybe try to tweak down the ventilator settings as much as we can to reduce the risk of pneumothorax or reaccumulation. I think that'd probably be a judgment call and be beyond my capacity, be up to you guys. But as if you're turning all the knobs in the ventilator, I'd probably suggest coming down the volume as much as you can and just increasing the respiratory rate so that you can decrease the peak inspiratory pressure. You can see here it's pretty high. It's like 26 or 30, right? So that's a pretty good inspiratory pressure that puts our patient at risk for a pneumothorax. But I think that's about it. If you guys had any final questions, please let me know, but it's been a real pleasure. Yeah, and please check out the website. Do you want me to write it down? Here, I can.
Does the Open Pediatrics website have the neonatal? Or?